Thank you very much, Anuswa. And first of all, thank you for organizing this instruction course. And I'm very happy to see a lot of LVP alumni and those with whom I've been associated with probably teaching or mentoring. Really happy to see that. So I'll be talking about management of recurrent OSSN. 1 second. Yeah, so first of all, I do not have any financial disclosures, and a consent has been taken for use of patient's clinical photograph. Now, the recurrence of ocular surface squamous neoplasia, it does occur. All of us who practice OSSN treatment have experienced to see the patients having recurrences. And it has been reported that after excisional biopsy, the range of recurrence can be between 0 to almost 60%. With mitomycin C, the upper limit is about 35%, 5-fluorouracil, much more, being about 40%. And with interferon, at this point of time, it is about 10%. But probably the interferon being a newer modality of treatment, the long-term results might be different. Now, talking about the recurrence of OSSN after surgical excision, I think this is a very informative paper that came from Bascom-Palmer, where they studied what are the risk factors or the predictors that can suggest that the patient is likely to have a recurrence after excision biopsy. And these are the things that are important. That is, whenever the patient has a higher AJCC staging, that means if the patient has a T2 or T3 tumor, they are 2 times at higher risk of developing recurrence compared to T1 tumor. And tumor location, again, the tarsal location, whenever it is there, they have higher chances of recurrence. Whenever the surgical margins are involved, they have higher rates of recurrence, and cryotherapy, when not used, can cause recurrence. And higher histopathology grade, like invasive squamous cell carcinoma versus a dysplasia, the patients with invasive lesion have more chances of having the recurrence. But if we go back into the literature, I feel the most important publication that came out in this is this paper, which came out in about 1986, where they studied different factors, and they showed that neither the tumor morphology or the cell type or the degree of dysplasia actually influence the tumor recurrence. It is mostly the tumor margin. And they showed that whenever the tumor margins are involved, the risk of recurrence is as high as 50%, which can be reduced to 5% when there are tumor-free margins. Now, this is another paper, an interesting paper, which came from an African group where they actually did wide excision biopsy, did not use cryotherapy because of non-availability, and they showed that the tumor recurrence rate is still only 3%. So this paper, I think this tells us that tumor margins are much more important than cryotherapy. Yes, cryotherapy can minimize recurrence, but the most important is acquiring free tumor margins. And whenever we do not use adjuvant therapy after surgical excision, if there is an indication for adjuvant treatment, these patients again are at higher risk of developing tumor recurrence. Now, how do we minimize recurrence? It's always prevention is better than cure. So we have to minimize recurrence by, first of all, choosing the cases wisely. We have to know which are the cases which are suitable for excisional biopsy, or should we attempt alternate modalities of treatment. Avoid iatrogenic tumor seeding. One is the most common mistake that surgeons do is keep on flushing the globe when they're doing surgery. Always try to maintain a dry field. Do not keep on pouring saline during surgery. That itself can cause tumor seeding. And second thing is using 2 different sets of instruments. Change the instruments. Do not use contaminated instruments in the non-tumor area. And try to get the tumor-free margins by taking white margins, use cryotherapy, and appropriate adjuvant treatment. Now, here are examples where a small lesion and a relatively larger lesion, where we are able to get a good treatment response where there is no recurrence, but that may not be so in all cases. Like here is an example where the patient had tumor recurrence within 3 months. And here you can see the lesion is in the area of previous tumor. Now here is an example where the patient had a tumor in the temporal area which was excised. The superior area was absolutely normal at that time, but the patient came back with tumor recurrence at a different site 5 years later. So we have to do a good examination to identify recurrences. Now, we also see recurrences after medical treatment. Now, this is an important paper where they showed that the recurrence rate of OSSN is similar either with surgery or with interferon treatment. And when we compare the response of 5FU and interferon, the results are similar, including the recurrence rates. And this is one paper where we try to see what are the factors that can influence recurrence after medical treatment. And it is mainly the size of the tumor which determines whether the patient can have tumor recurrence. Now, here are some examples where they have very good response. This is after 5FU, where the tumor completely regressed. And this is where we used interferon and there is complete tumor regression. But again, that may not be the case with all cases. Like in this case, we used interferon. He did very well with just 3 months of treatment. But 3 years later, he came back with a tumor recurrence. So recurrences can occur after medical treatment. So how do we go about treating these cases? Now, first of all, before we start treatment, it is very important to confirm the diagnosis, rule out if there is any extension, and do appropriate investigative modalities. Now, here is an example where the patient underwent excision and came back with this lesion, and the patient was concerned that there is recurrence. But is this truly a recurrence? Now, this is the OCT, which shows that it does not have any features that Vijita described in the first presentation. So if we compare it with OSSN, where we see that abrupt transition and the hyperreflectivity and the lesion being epithelial, all those are missing in this. So the first one, of course, that is just an example of how the OCT OSSN looks. And this is not OSSN. The one that the patient presented to us with is just a simple pyogenic granuloma and not a OSSN. Now, here is another example, the same patient that I showed you before. Now, this patient underwent excision biopsy for the recurrent tumor and then came back with this lesion, and the patient again was very concerned that this is recurrence. Now, is this recurrence? Definitely not. This is just a corneoscleral cyst that has occurred at the surgical site, and the OCT confirms the presence of the cystic spaces. Now, this is an interesting case where the patient had history of OSSN in both eyes, underwent excision biopsy, and came back with this lesion. If we see closely, there is a corneal lesion that is present in the right eye, and the left eye doesn't look like that there is recurrent OSSN. Now, let's just see OCT to confirm the diagnosis. So this is the first case, and you can see that there is abrupt transition between the hyperreflective epithelium and the normal epithelium, confirming that there is OSSN recurrence in the right eye. But this is the left eye. Left eye, you see that the lesion is in between the stroma and the epithelium. So this is just a corneal opacity that is present, and it is not OSSN. So the right eye is recurrent OSSN, while the left eye is simple corneal opacity. Now, this patient came back with recurrent OSSN, and appropriate imaging is important, as can be seen. This patient on UBM showed intraocular extension. And this is a patient where underwent excision biopsy, underwent extended enucleation, was doing fine, but 8 months later came back with a suspicious lesion. So in fact, this patient had recurrent OSSN, and which was extending deep into the orbit. So it is always important to do appropriate investigations to know the extent of the lesion. Why is it important? Because the treatment of recurrent OSSN, you can use the similar modalities of treatment like you use for primary treatment, but the extent of the lesion should be very clear. Now, this is an example where the patient had recurrent OSSN after interferon treatment. He was not compliant to treatment. So we went ahead and did simple excisional biopsy, and he did fine. So excisional biopsy is a good treatment modality for recurrent OSSN. Now, this is another patient who had multiple recurrences after surgery, and we combined it with SLET because he had extensive involvement, and he again did fine. Now, when do we use Plaque radiotherapy for recurrent OSSN? So this is an example where there are multiple recurrences after surgery, and we can combine excision biopsy and Plaque radiotherapy, and they do fine. And this is one more patient who had recurrence after excisional biopsy. And it was a very ill-defined lesion histopathology, confirmed recurrent OSSN. We directly did Plaque radiotherapy, and he did fine. Now, this is a patient who had recurrent OSSN after excision biopsy elsewhere, and you can see it is extensive lesion. We used interferon alpha 2b, and you can see that excellent response with medical treatment. So medical treatment, again, is a very good treatment option for these patients. Here is an example where 5-fluorouracil was used in this patient because he did not respond to repeated excisions and interferon. He mainly had the corneal disease, and after 2 cycles of 5-FU, you can see that his cornea has become clear and the disease completely resolved. Now, extended enucleation is required whenever there is intraocular extension, like in this case, and orbital exenteration may be required in some cases like this, where this patient underwent enucleation, came back with orbital recurrence, as can be seen on imaging, and he underwent orbital exenteration. So any modality of treatment can be used for recurrence. We have to use appropriate treatment, and good examination is important. So with this, I complete my talk. Thank you very much.